So, good afternoon, everyone. Thank you for joining us. My name is Mark Driscoll. I am the program manager for the Ohio AAP's Preventive Health Program. I just have a few words to say, and then I will kick it to our speakers. For those of you that will be applying for CME or MOC Part 2 credit following the presentation, I will send an email either by the end of today or early tomorrow that will give you that link to apply for your credit. So, look for that in your email. And then I was just going to welcome you to our next two webinars. You'll see a link in the email as well. We are focusing on vaccine hesitancy and hypertension. So we look forward to seeing you at those. Otherwise, I'm going to kick it off to Dr. Bowling to get things started. Thank you.
Welcome, everybody. And we were just talking about it before we all signed on there at Go Redhawks. I hope everybody's cheering on the Miami Redhawks right now. They looked amazing last night. So, anyway, what we're going to talk about today, we're going to talk about from adolescence to adulthood, tips on navigating the transition from pediatrician to adult medical provider. This is something that I think we don't talk enough about, actually. Um, we've Our learning objectives are pretty straightforward. To learn how to develop, you can use development to sort of guide you through this process. To compare and contrast how chronic conditions differ between pediatric and adult patients, and list some important tasks that we all need to accomplish as we're transitioning kids. We're also going to try to give you some good resources on this as well. We have Dr. Lazaron and I have no disclosures to give you, and with no further ado, I will uh, hand it over to my co-presenter, Betsy Lazaron, our friend here at the Ohio chapter for many, many years. And I was thrilled she was able to do this with us, and I'll hand it over to you, Betsy, to introduce yourself.
Okay. Thank you, Chris. I'm thrilled to be able to talk to you here today because in this last year, I've had my own transition from full-time practice. Now being able to focus on the parts of my job I've always loved, which is teaching and mentorship in the medical community, and then working on special projects at the Timothy Freeman Center for Adults with Disabilities, focusing on transition care from pediatric providers to their adult medicine providers. Um, so this is a topic that's right up my alley and something I am passionate about, and I'm glad to be able to work with Chris on this.
Thanks, Betsy. I'm very excited about it too. Thank you very much for agreeing to do this with us. We as pediatricians really value our family medicine colleagues and our internal medicine colleagues in this endeavor. And as Betsy said, I'm also going through a recent transition myself as I retired about 3 years from active practice and have continue to be active with the Ohio chapter and with National AAP on a variety of topics. So let's talk about what I was mentioning at first, how we use milestones to kind of guide us through the process. As pediatricians, obviously, we're pretty good with going through developmental screening. And there are some really big implications for transition of care. We need to really continue to think about kids through a developmental lens when we're talking about this transition of care. If we remember, like our stages, these early stages where we're not doing a whole lot of transitioning care yet, we go through those usual milestone considerations of magical thinking, early independence, more recognition of what other kids are going through. So that's a slow progression. Betsy's going to talk about this a little bit, how we do this in reverse on the adult side. But for now, what we talk about, these early phases, we're all very familiar with them. As kids get older, as we move into middle and later adolescence, we really should start the process on how this transition is going to look. When we talk about things like chronic disease, even middle adolescents begin to get an awareness of other kids that are suffering from similar issues, but they still don't want to really talk about it in terms of the illness process itself. They're more a little focused on their own development, their own world, and their chronic disease is just a part of that, like it is for adults also. But I think really for kids, there's still a lot of this thinking like I'd like to talk less about what my illness is and more about what I'm going through. What we find with later adolescence is we really get into that growing independence, that ability, and the necessity of actually managing things on their own. There still is a varying level of parental support that's required, I think, even until your 30s and beyond. But in general, it's a general move toward greater independence.
A lot of what I'm going to be talking about is how you can prepare to foster that autonomy with support as needed, and particularly in late adolescence. The preparing to launch. We launch children in many ways as they go out into the real world, but launching them into the medical community really takes a lot of complex planning and grade aided support to have somebody who has any sort of chronic medical condition to be able to land well.
And it really is sort of, as Betsy and I have been talking about this, there is really a lot of shared decision making. Just like as the adult providers often chosen by the parents, but the emerging adult also needs to make sure that they can form a therapeutic relationship with that person. I think we all notice that, like when you get referred to somebody and you wind up actually seeing that person's partner or another person in the practice, being open to that kind of independence and that launch is really important. Let's talk a little bit more about emerging adulthood. We sort of define this as between the ages of 18 and 30. We see patients currently living with their parents longer. We see a delay in marriage, career, parenthood compared to earlier generations. I don't even say, which is something that just boggles my mind, a delay in getting a driver's license. Even in communities where there's really not great public transportation, there are a lot of kids who don't make that step either until much later. Sometimes that autonomy needs to be reiterated and reinforced. Um, 18 to 21 is when I'd say most pediatric providers will transfer their patients to adult providers, but that's not universal. Betsy, any thoughts on this also?
You'll find this happen earlier sometimes when there's people who find themselves in a community where there's not a subspecialist that they may need who's available in a specific pediatric context. And so they're suddenly finding themselves seeing an adult cardiologist, an adult endocrinologist, because a pediatric subspecialist isn't there. And finding that making the transitions to care in that subset of visits is actually a good preparation for what's going to happen to them later.
And I think that there's a lot of variability. I think that variability is based on your location is really very present and appropriate in a lot of circumstances. I'm still amazed at how many patients would say to us, "Oh, can we still come here to your pediatric office as teens, or should we switch them over at like 12 and 13?" And I think most pediatricians would say, "Oh no, we feel very comfortable with adolescents." But there really is a gray zone. It really is very appropriate to make those sort of decisions as a practice and make that transition based on what your resources are and what your situation is.
Yeah. And there may be times where it's not due to a chronic medical condition, but an acute condition like pregnancy, where that transition may
Correct.
occur a little faster.
Absolutely. I think it's useful to really make a little bit of a comparison between what does pediatric care and what does adult care look like, just in general. I think we know, but I think it's worth it to kind of call this out officially. So pediatric care, how it differs is, usually patients from birth to 18 to 21. It's very family oriented. Not saying that adult care in family medicine offices is not, but it's very family oriented in pediatric care. There's a lot of parental decision making, clearly, out of necessity. There are more members of the interdisciplinary team. There tend to be a lot of other people sort of factoring into this in terms of school members, other caregivers, lots of other like professional and non-professional people who are involved in the care. In some settings, appointments might be longer. And that's something that a lot of patients have a difficult time getting used to. While in adult care, and I'm going to have Betsy chime in with me through this as well, because she can speak to this more accurately than I can. We talk about at least age 14 and older.
Mhm.
Family medicine is obviously cradle to grave. Um, Patient specific as opposed to family specific. There's a real need for autonomy. We can kind of get by. I think there's a mythology that the parents are making the decisions for the kids all the way through to graduation from high school, when really kids start making a lot of their own decisions even in first grade.
Mhm.
But there's a real need for autonomy when you move to adult care, legally and developmentally. Not as many interdisciplinary resources available. You don't have a school psychologist. You don't have resources at childcare. You don't have other sort of wraparound services in general. And there's a real, I know in, in a lot of social services agencies, that's a real gap for that young adulthood. When kids time out of the foster system, a lot of those wraparound services disappear, going into the adult world. And there's a little bit more variation in the appointment length, which is something, like I said, is difficult for families and kids to get used to.
And there often seems to be more flexibility within a pediatric practice. I don't know if that's actually true, but I can feel the terror when somebody's there for a visit for strep throat and says, "Oh, by the way, I need to have this form completed for my college physical. Can you just, oh, by the way, do that today?" And I'm sure, Chris, you've probably been on the
Oh, by the
side of
way,
that as well too. But um, in an adult medicine practice, it doesn't fly. So you're going to be asked to make another appointment of a different length to be able to accommodate some of those things that may have been more flexible or more ability to adapt in somebody that you've been seeing for a longer period of time. I do want to add the one unique rainbow unicorn of medical providers to this list of adult care, those people who are double board certified in both internal medicine and pediatrics. If you happen to find one of those who does outpatient medicine, you have hit the nirvana of care. So we didn't put them in there because nobody's going to be able to find one very easily. But when you do, transition suddenly is not an issue for you.
it is, at least in a very different way. Absolutely. No, I appreciate you mentioning that too, Betsy, about the yeah, the oh by the way stuff. I just assume that the oh by the way stuff happens. But you're right. I wouldn't think of asking that of my internist. Like, oh, can you also do this while you're in there? I think
Yeah.
we as pediatricians do that a lot.
Yes.
So the transitioning of care is a very specific regimen. I should say, well, maybe not very specific, but a general regimen is recommended by all the major organizations: the American Academy of Pediatrics, the American Academy of Family Practice, the American College of Physicians, and the American Society for Internal Medicine. So there are some very standardized things, and they all recognize how important this is. So we're not alone in trying to figure out and how to handle this in an appropriate way. Um, Keeping in mind the goal here is that the age of transition is somewhere between 18 to 21 on average. The AAP recommends starting this discussion at age 12. So we're talking about that transition sort of between early and middle adolescence, somewhere in that zone as the kickoff time to start this discussion, which seems early, but really I think is a great time to get started. We talk about some critical steps along the way in getting through this process. So, step one of the critical steps, you want to have uh, someone identified the special care healthcare needs. You want to have start identifying a primary healthcare provider who can attend to the patient's unique challenges and assume those responsibility of care needs. So to start thinking about who that is at a young age. I mean, I think it also starts off by you kind of having someone who's primarily responsible for this in the pediatric office. So make that transition easier when that comes down the line. So really trying to make sure you're identifying somebody on the internally and then some general ideas where you're going to be going afterwards as early as age 12.
What sometimes happens is the default provider, the adult provider, becomes whoever the parents adult medical provider is, that may not always be a good fit for the child. May be geographically distant, may have a range of practice that does not include the needs for that individual. So really having this be focused on what that adolescent needs to be able to be well served in their new medical home.
You mentioned also too, Betsy, about med peds providers. One of the really good groups that we would often transition our patients to, some of our medically complex patients would go to med peds providers, and they are, as you said, they are really few and far between in some steps. So identifying somebody very, very early is helpful because sometimes there's just a really long wait, a really long process to get into those practices as well.
Yeah.
You want to identify core knowledge and skills for each patient that are going to be needed to provide. I mean, not that you can predict everything well into the future, but you certainly your patients with cystic fibrosis, your patients with diabetes, your patients with juvenile idiopathic arthritis, those patients are going to have specific needs moving forward. So it's helpful to identify what those core knowledge and skills are going to be that you're going to need moving forward. You want to start preparing an up-to-date medical summary that is portable and accessible. This is something I think we all complain about at different points about our electronic health record. What a game changer.
Yes.
Becoming comfortable with your electronic medical records, particular generation of this up-to-date medical summary is mint. You really want to become familiar with this, whatever that means for your setup. You really want to become comfortable with it.
And that is so critical. Being on the receiving end of somebody who has comes with medical records that are full and really highlight the issues that are going to be important for that person is such a game changer on making a smooth transition. And then also that's becomes part of the process of achieving independence. So that person, whether they've got a paper version of a one-page medical summary, the one-page medical record, or whether they become fluent in being able to access their own medical records independently through a patient portal. And so able to start doing things like requesting their own refills or scheduling appointments through that is one of those electronic links that maybe the younger generation is maybe even more comfortable in than their parents.
And I think that's a really good point. I mean, that medical summary really does. I think you can notice it with yourself. Like, okay, I don't need to pour through all these medical records to get a snapshot of what my provider thinks about my medical care. This is something that I can kind of get my head wrapped around when I see 6 problems that are being managed. It certainly assists everyone with knowing, like, okay, I'm adherent to all the medications that I'm prescribed. This is the one that's a problem. It just allows that clarity.
Yeah. And if that in for individuals who have complex needs, if that medical summary also has what specialists they're seeing with you attached to it, that is a major bonus for people who have additional medical complexity.
People forget, like, oh, I saw that one person. What was that one urologist's name? And anyway, and I think you and I both discussed about how that used to be. We used to both have like that paper, that sheet in the front of our
Yes.
chart that was our problem list. Certainly becoming comfortable with your own EHR's generation of that is really, really important. Development of up-to-date and detailed transition plans that you develop in conjunct collaboration with young people and their families is very helpful. Again, this is a little bit of a later of the critical steps, but really kind of sitting down and saying, like, okay, here's where we're headed. Here's what we need to be thinking about. Here are potential areas that I think you really want to get in with this one person or this one group, or to say, like, okay, this is going to be an area that's going to be a gap that we're going to need to figure out how to address as we get closer to that transition time. You want to make sure that that standards for primary and preventive healthcare are applied. I think this is sort of just one of those statements, like, you want to make sure that you're comfortable and that they're comfortable with, like, what does it mean to be going to um, a, a, a a provider who's going to provide the same sort of care that they become accustomed to.
And often pediatricians, it's part of the lift that they do. They already know they've taken care of patients with, say, Down syndrome for years. They know what preventative care measures may be unique to a certain population set. That may not be firsthand knowledge to most other people who do adult medicine. So those things that are going to be important to monitor or screen for in the future, please pass it on to the rest of us. We
Yeah.
appreciate all your expertise.
That's a great statement. I mean, I think that's especially important for our rural providers who, like you might need to remain a little bit of while you might not be their primary care person, you might need to be a little bit of a resource on how, kids with Down syndrome have thyroid issues or how, some of the other things that just may not be common knowledge for another primary care doc who takes care of only adults. Number six, I think, is one that we're going to have to really keep our eyes on because, as we know, kids are covered until 26 on their parents, which is great. But parents are not as widely covered. I'm worried about what's going to happen over the next couple of years with access. So we're just going to have to watch how health insurance coverage kind of plays out on the exchanges and elsewhere. It just we're not in a great space. Without saying anything more, I'm not sure exactly where we're headed on that one, but we're just gonna have to watch because this is a group, those young adults are the ones who roll the dice on being uncovered. So we're just gonna have to watch and see what happens.
Yeah. And that health insurance that's provided by your parent may not be quite as portable as you think it is. If they've got your parents have a regional health plan, that may not be
Great
there may
point.
not be providers in the location where you decide to go off to college or where you're first living when you're out of the home. Um, and it may not offer the same services that you've come to expect that are available in your primary setting. So,
That is a great point, an absolutely great point. So if we look at the six core needs, this is our first resource. These are all going to be present and logged for you, so you can come back to these. The core needs are sort of in a PDF that you can access here, and then also there's the track questionnaire. There's some other sources that other ways you can assess this, but the track is a pretty good document that you can use to assess these six core needs as you move through. It's called the track questionnaire, and it goes over these core needs. There are some other tools that you can assess the track scoring I mentioned. You can use what's called the Healthcare Transition Process Measurement Tool. There's the Transition Feedback Survey for youth, young adults, parents, and caregivers. And so there are resources out there to help you do that. There are some things that we still are lacking, however. There are really some places that smooth transitions are very difficult, no matter how much preparation you do around them. Geography really makes a big difference. We've sort of mentioned it already. I don't need to tell you, for those of you in certain communities, that it's really difficult, and it may slow your ability to transition kids because there's just a lack of providers. We also think that there's not as much training around this as there needs to be. Certainly, Betsy is very involved in doing this with her family medicine residents. I think it's something that we need to really work more on with our internal medicine and pediatric residents. As I mentioned, there's a severe lack of providers still. And one thing that I would say a lot of us still deal with is patients and families, and sometimes even pediatricians have a difficult time sort of letting go. Um, it's just tough. Certainly, the lack of facility with young adult medicine, they're definitely a transition in a number of ways. And sort of going back to that thing where you may still need to be a little bit of a resource for your adult medical providers because it's an area of some discomfort for some.
yeah.
Um, Betsy and I, we were talking about this slide. We said, do you want to do this one? Do I want to do this one? Because this is an area that we both really feel very passionate about, are our kids with special healthcare needs. These are the ones, certainly transition is really important for everybody. However, the ones we worry about the most clearly are our ones that have special healthcare needs. And that could be any number of things. Chronic diseases like diabetes, asthma, genetic disorders like Down syndrome, but any sort of medical complexity really is what needs to be talked about with these patients. These are the
Yeah.
ones who we really worry about.
The kids that you've taken care of in the hospital for crises that you've managed to get them through are the ones that stick with you. They're the ones that you worry about at night, and those are the ones that um, are the ones you want to make sure that when they land in some place where they can get the kind of care that you want for them.
And some of them are obvious, some are less obvious. Certainly our patients with the mental health crisis really makes that a bigger issue. We have so many kids with anxiety and depression and such a shortage of providers in this area that kids with mental or behavioral health conditions, I think we see so many of them, we kind of forget. They're really truly our kids with special health care needs. They're ones who need a little special assistance with this as well, because that's a big change. Certainly our patients with other social complexity, I'd also say are ones who need some special attention. Our LGBTQ kids, our immigrant kids, our homeless kids, our kids in foster care, they all are at higher risk for being lost in the system. And having a more difficult time finding an appropriate provider. So those are ones that Betsy and I feel especially at risk in this process. So the ones to pay special attention to.
And when in the adult realm, when we try to find resources in that mental or behavioral health and the social complexity, it's like emerging from the pediatric world, you almost fall off the cliff. Um, Trying to find the number of behavioral health specialists that are available to meet the need in the adult realm doesn't even come to parity with what you need. For social complexity, some of the supports that are provided um, institutionally as well as by families, school-based care, foster system, just disappears once they've graduated from school and graduated from living in their court assigned foster care. So one of the things that really tends to be the biggest condition that we have and when people are facing what do I do next when I need to find a primary provider, it's the who are you going to call? This is the Ghostbuster slide. Who you've always called before when you've needed help with things like a sudden illness or to get your physicals done, like your school physical, your work permits, your sports physicals, your health maintenance exams. These are things that are now going to be done by your primary care provider. Um, and that's going to be usually your family doctor, your internal medicine provider. Um, and then if you need information about your diabetes or the hypertension or cholesterol meds that you may have acquired as part of the care for complex conditions like your diabetes, this is where you're going to get the information from primarily. Um, the and then when you're trying to find, maybe you're trying to merge care between a couple of adult specialists. You're seeing a gynecologist for prescribing birth control or an acne medication from a dermatologist or depression medicines, finding out which ones are compatible with your diabetes medicine. Maybe something you're coming back to your primary care provider to find because, you know, not that many dermatologists know that much about diabetes. I'd love to say we all have a broad range of knowledge, but for some of them, it's not an area. For some specialists, some of these crossover areas are not something they've touched in a very long time. So you come back to your primary care physician to help you navigate between complex care. And sometimes that becomes an issue. So, and then just getting the help you need to find a specialist who treats adults. So if you are somebody who's needing to see an adult ophthalmologist because you now have some diabetes complications that may be affecting your retina, finding somebody who actually performs that service in the adult realm may be something where you come to your trusted partner, your primary care physician, to find out who would be a good fit for you. And also, who's on your insurance, which becomes uh, a bigger issue sometimes when you're trying to find a subspecialist who may be in limited supply. Now, Chris presented just a really wonderful um, synopsis on progressive stages for developing autonomy. In the adult realm, we talk about ADLs and IDLs. And I have to say, this comes from our experience at the other end of the age spectrum in geriatric care, as people start to require more support in their elderly years. We talk about the ADLs, needing help with feeding, bathing, dressing, walking. These are all things that you would think of in early childhood where a parent needs to assist with you being able to do these basics. IADLs become something that we talk about in the adult realm a lot, but is something that as you transition in a late adolescence that you may need more help with. Anything you do in that realm that the parent does or that the pediatrician does in helping support that independence in IADLs is going to make a smoother transition. For parents, that may be shopping, meal prep, knowing how to count your carbs for your diabetes, finances. For the primary care physician or the pediatrician, that may be managing medications, more discussion about how these medicines work, and when you should skip them and when you should never skip them. And then learning to manage communications. So it's being able to manage communications to pay your bills, but also to be able to request a refill of your medication without having to call your parents to make sure that these things are happening. Within diabetes specifically, because that's one of the areas we're most focused on, the nuances of things like carb counting. They're going off to college. There is going to be alcohol involved. How do you carb count alcohol? It's not on the label. Your primary care physician can help you with that. How do you place the CGM when you don't have a parent to slap it on the back of your arm for you? And how do you monitor yourself? And then things like insurance payments, premiums, copays, deductibles, needing prior authorizations. We all struggle with that, even within a medical practice. Getting out of network medical care, referrals to specialists. These are things that the pediatric patient as a young adult starts to require more active management to be able to affect these things for themselves. Next slide. Now, the communication styles that a parent uses, that a primary care physician uses, the pediatrician uses, may change based on how much self-efficacy the person has. The do it because I said so is something I say often to my 2-year-old grandchild. But in that authoritarian model was probably more common in medicine years and years ago. You seldom hear that from any of us. And often in early childhood, we start to transition to, or at least early adolescence, this is the best option because. So you're still being very directive, but you're giving them a reason why. So warning your pediatric patients as they go to see a subspecialist in the adult realm is most of their communication will probably happen in that consultative model. You're here to see me because I'm the expert, and this is what I strongly suggest that you do because it's the best option. Now, many of us, family doctors, pediatricians, really live in that collaborative model of shared decision making. This is something, there are options here for care. This is what I recommend. What do you think about this? Is this feasible for you? Is this something that you can do? And I'll have to remind people that that isn't how all of the medical community works. But as you have conversations with your patients, you start to be able to move to more that collaborative sort of discussion, which allows them to achieve more independence. Now, there are times when you have to actually kind of lay down the line and say, this is the kick them out the door phase where I'd say, I want to be supportive and you want help with this. And I have to tell you, this is my boundary. This is all I can do. So often people in their adult world, as they start to get more autonomy for the care of a complex condition, decide that some of the things that you think are medically indicated are just onerous to do. Why do I have to keep taking this insulin? And you have to set a boundary and say, This is definitely in your best interest. Please, if you stop your insulin, make sure you are still monitoring your blood sugars. And if they go above 300, you call me right away. If they go above 600, you're going straight to the emergency room. So giving people boundaries to let them know um, what you have to do is something that you're going to find happens more. It's no different than the parents saying, um, you would really like help buying a car? This is what I can do. And it's only this much. So, next slide. Now, there are some practical supports that parents can provide, physicians can provide, that help make the transition a little easier. The fact that dependent insurance coverage is available through the age of 26, is a huge factor. You don't fall off the cliff when you graduate from high school anymore. You are still available. Um, and for somebody who has truly complex problems with disabilities that require them to continue as an adult dependent for a longer period of time, that insurance can continue. I certainly have 45-year-olds with Down syndrome who are still on their parents' insurance. That requires a little bit of documentation to be sent off to insurance companies, but can exist. Um, Remembering that that dependent insurance coverage, though, is really geographically limited, and that too is a cliff that people will fall off. Um, Medicaid and managed care plans are often state or region specific. So, as people need to plan for that or plan for another resource for their medical care, medical insurance, if they're moving to a place where their parents' insurance don't apply. So, maybe they're on a managed care plan, they're going off to college, they may want to be signing up for student health insurance in the region where they're going to be so that that continues to be available, care continues to be available to them. Um, some of the things that physicians can foster and that families can help with is setting up things like proxy access to medical records, pharmacy records. So if your adolescent is not quite ready to make that transition to getting all their refills done on time, um, allowing them to have, providing the adult that they trust with some proxy access to help them with things like um, uh, getting medications refilled or requesting appointments may be helpful. That requires a level of trust because often having proxy access means people can see everything in your medical records. So if you're not comfortable with your adults of the your parents seeing things like what type of contraception you're using, then that may not be an option for everybody. And one thing I want to talk about too is the durable power of attorney for healthcare. It is not just for geriatrics. This is something that allows young adults to make a decision about who can help with access to their medical records at a time when they can't. So if you're a 22-year-old not living at home anymore and are in a car accident, rendered unconscious, and need help negotiating your medical care with that, state law is going to defer that to your closest relative, who's your parents. If you're already living independently and you prefer that healthcare proxy access be your not partner that you're not married to, this is something you can put in writing, and it will be followed and honored. And it is a useful thing to have. It may change as time progresses. Most people think of this as their living will, and you only sign one of these things when you want to be DNR. No, this is the person who helps choose the rehab facility for you when you have such a severe concussion that you can't make that decision independently. So these are all useful things to have that you can facilitate now.
That's a great suggestion, Betsy. I think we don't think about that. That's a great suggestion. So, this is a lot of this is we're going to show you some different resources at this point. A lot of this is covered in a clinical report. This is kind of an outdated one. It needs to be renewed. I'll be very honest with you. This is a clinical report from the AAP on supporting the healthcare transition. While it's not officially, they get retired after a few years, this will need to be affirmed. But the AAP does have resources on healthcare transition that kind of go over these things. If we look at it graphically, I love this slide, which actually sort of supports it. This is from that clinical report, but basically gives you a summary of what this has looked like from age to age. You know, at the 12 to 14 age group, you start talking about what the policy is and what they're going to experience over the next few years. At 14 to 18, you're starting to track process and you're starting to start establishing what it is you're going to be looking at. You just sort of setting the parameters. You know, first you sort of lay out the policy. Secondly, you sort of say what that policy is going to look like and what you're going to track. From 14 to 18, you're kind of doing a couple of things here. You're actually assessing their ability to follow the plan, and you're starting to establish that medical summary and developing the transition plan more fully, like maybe even coming up with some specific names, some specific practices, some specific strategies around particular challenges. So you're really going from that, you're going into that phase where you're assessing their readiness to change and their planning. This sounds like a lot, but we're talking about really just touch points. You know, like, do we have a plan? What are we going to monitor? Now, are you ready for it? What is this plan beginning to look like as they go through 14 to 18? So it's very quick. You're not like kicking them out the door right away. You're just sort of building the foundation of what this transition is going to look like. And then somewhere between 18 to 21, the actual transfer occurs. And also with some follow up, where you actually then make the decision where they're going to go, how this is going to happen, and then you confirm that everything happens. I'm going to use this slide also to talk about one thing, and I'd love Betsy's input on this as well. We always debate, like, we had a policy in our office, and I'm not sure it was the right policy, but it was the one that we followed, where we had this hard discussion, not a hard discussion always, but we had a discussion with our patients who were turning 18. Are you going to college? Are you going away to college? And are you going into the career that you're going to be going into? For our kids that were actually going into a career, who were actually moving someplace permanently, they were ones who we said, you know what, this is a great time to transition. You're probably going to have different insurance. You're probably going to be where you're going to be set for a little while. It's a great time to make that transition as you're finishing high school and starting your trade, starting your full-time job, becoming an adult, and in all those ways. You're younger than the other people who this is going to be happening with, but it's a great time because there's these other natural things that are occurring. For our patients that were going away to college, we were sort of the opposite. We were sort of saying, like, you know what, you're probably going to be in Gambier for 4 years. So, and you're only going to be there for 15 weeks twice a year. So it's like you're not really the place where you're going to be permanently, and you're not going to be there all the time anyway. You're going to be sort of splitting half and half, and you're going to be home a lot. So with those kids who were going away to college, we would make sort of a statement like, you know, why don't you hang on with us? It's going to be easier for us to sort of like manage things for you at a distance because you know us. You're not going to have to get to know somebody new right away. And then our kids who were going to college, they weren't necessarily going into their the thing, but they were going to UC or Xavier. Those kids we would say, or Cincinnati State, we would say, why don't you let's figure out what the right thing to do is. We've got some time to figure it out. Maybe there's a really good point along the way here where you're in town, but now an adult, that we can make the switch over. It might make more sense for you if you know in 2 years you're going to be moving to Denver just to stay with us and not to go to someone for 18 months. But it might also make sense, like you're co-oping for 4 years. Maybe it does make sense, and you think you're going to be with that employer moving forward. Maybe it makes sense to make the transition then. So we always had this discussion in this 18 to 21 range, what make most sense for them individually.
And I appreciate people who do that transition and start thinking of it as a real thing. As because from a patient's perspective, it can be really like for them too, also falling off the cliff when they lose that provider that has cared for them for a number of years. I will share my personal experience. Coming home from college when I had just turned 18 to have my pediatrician walk me out to the waiting room, point to his waiting room and say, see all those little chairs, Betsy? These are for small people. It's time for you to find an adult provider. Never want to have that happen to you. So
That's traumatic.
It was traumatic.
There are some resources. These are a couple of forms that we're going to share with you on here about how this might look in the letter you send out. I know that's something that's always a difficult thing to know how to break this news, which could be upsetting to your patients. So this is one where these are some different letters that we will have on our site that show you what these different letters might look like. Yeah, again, you can just kind of use these as a frame of reference if you need to when you need to communicate with families. If you're transitioning to an adult model without changing clinicians, it may look different. Although there are changes. Like I'm sure Betsy, you have different expectations for a 20-year-old in your practice than you do a 16-year-old in your practice who you've taken care of. So sometimes there's some utility in saying, like, now this is what's happening with you as you become 18.
And we get a lot of experiences, this heavy lifting about um, releasing test results. Do you release it to the child? Are you releasing it to the parents? Which ones are sensitive that um, may only be released to one individual? Which ones are critical that you want to make sure that many eyes have a view on because they may be condition or a concern that may be life threatening. We talk about this all the time as people in adolescence when they get their own um, access to their EMR. You already have started some of this in that young adolescence, as well as those visits that may be constrained from review by a parent
Mhm.
when you
Yeah,
talk about sensitive subjects.
and some of those things like that medical summary, those are things that are good for our young adult patients to have regardless of where they're going. So yeah. We're going to do a quick case. We won't spend a huge amount of time on this, but let's talk about Tori. We've got some questions for you. Tori is an 18-year-old patient of yours from birth who also has type 1 diabetes, diagnosed at age 8. She's been relatively well controlled, but had a stretch from 14 to 16 where she had very poor control. It was at this age that she was starting to identify as gay and was struggling with telling her family, becoming depressed during the process. After her family embraced her and supported her unequivocally, she returned to good control. She's graduating in June and is going away to school next year to the University of Toledo, majoring, not measuring, in psychology. What questions do you have, and what challenges with transition do you anticipate? So, what's the goal here? It's like what are the big issues? What do we really want her to accomplish here? Any thought?
Yeah. Can she manage her ADLs? Yes, she can. She's ready to launch from that regard. But can she manage the IADLs? Can she take her medication, know how to um, monitor her blood sugars if there tends to be a problem, know where the touch points are that could be an issue to sending that diabetes out of whack. Um, can she find the social supports that she may need in a new setting um, to be able to meet some of the other issues that she may have had? Um, can she find a community that she also finds that she gets emotional support from? If she needs a mental health therapist, is that something that she's prepared to be able to find on her own, or is she going to need help with?
We have a couple of great questions in here. Jennifer Hardy said, what sort of kind of support will be available through her college health service, which I think is a really good point. They're not all created equal.
Yeah.
Um, Chris Peltier said, looking at getting health insurance through the college recovery health insurance coverage, especially if hospitalization is a risk. It may be more cost effective in the long run. Great suggestion. So really understanding what's going on at the college and what their resources are. What are the monkey wrenches? Boy, there's a lot. There's a lot of things that I've seen so many things go wrong. Yeah, like lack of a hospital that's comfortable with kids, just all sorts of things. Um, Other things we need to ask. I think we sort of covered a lot of those. We have to really, I think, what the nuts and bolts that you were talking about, Betsy, are really important with these kids. Like what does this look like? What are you going to do if your glucose is 600? What does that mean? Being very specific is still very appropriate, no matter what your age is. Just having
Mhm.
kids kind of go through the very specific questions on this. And really, what are our needed resources? I think again, the comments about the college is going to have some bearing on that as well. And we have to think about how we communicate this stuff to her family too. It sounds like they've got a good relationship. You brought up a little bit, I've definitely navigated, and I think we all have, like, okay, Dr. Bowling, I just came back with a positive chlamydia test. What does that mean? And, what does this mean with communicating back to the family and talking about what does this look like when the explanation of benefits comes through to the family? I think that, those are practical questions that are very appropriate with this age group. So, what are our take home messages here? They're pretty basic. Think developmentally, pay attention to all the confounders that are out there with the social complexity, medical complexity. Make some clear shared goals that everybody's in agreement what this transition is going to look like. Start early, probably around age 11 or 12. And use resources and establish office policies and materials that work for you. Your particular setting is going to have a big impact on this. And look at the different scoring systems that might be helpful for you. Don't adopt them just to be adopting them. Adopt them because they help you. We want to show you a couple quick resources. Melissa Gittleman tipped us off to one from Central Ohio Pediatric, Central Ohio Primary Care. Let's take a look at this one real quick. This is a wonderful one. Betsy and I have already started sharing this. This is Teaching Kids Healthcare Independence Age by Age Guide for Parents. So it's a very family friendly website on how to help prepare, how to start conversations around health, age by age guide to building independence through each doctor visit. I think it's a great way to kind of help guide kids through the high school years and beyond. But it's a great little resource. We really recommend you check this out. This is sort of a late breaker, even some specificity around asthma, allergies, diabetes, but a nice little website from Central Ohio Primary Care that's available to all of us. There's another one that we like. This was thanks to Betsy for this one. This is a great resource from the Ohio Bar. You can wind up seeing a lot of things that are very expensive. This one is free on the Ohio Bar. It's actually a healthcare power of attorney that Betsy mentioned that you can use. It's got also the power of attorney on it um, with all the necessary legal verbiage around it that are very helpful. And again, even if you don't use the exact one, certainly gives you a good framework and good ideas on what to look for when you're looking for this.
Okay. And this resource is something we use in primary care all the time. It's part of every Welcome to Medicare physical, but I realize that may not be something that is quite as available in the pediatric realm. So having this available as a resource that you can use can be helpful. This is just happens to be one that doesn't have any paid firewalls to it that you can download for free and have available as a print copy or send as a resource to families. It downloads to the legal document that requires either two witnesses to sign or to be notarized by a notary public. And then you can use it for medical records or for medical directives anywhere in the state of Ohio.
So with that, we'll kind of see if anybody has any questions. We have a couple minutes here before we hit the top of the hour.
Chris and Betsy, thanks. I don't have a question, just more of a comment, and it kind of goes along. You sort of hit on this a little bit about sort of power of attorney. Especially, there are some that many of them have a slight fee to use these services. I know, like Mama Bear's one, we used it for our kids when they went off to college, but they have like a whole suite of like medical power of attorney, healthcare power, other like things as your kids, especially if they're going out of state for school. So I think it kind of goes into what, Betsy, you were saying, some of the forms you can get. So just sort of having like a whole suite of sort of resources. And I don't think that's something that we really, I know I don't talk about. We're really trying to figure out sort of how to do that. And part of that was sort of, we were kind of had to, because, this is one of the things, those of you that participate in the CPC for kids, it's one of their measures. And we were doing some things, but we've realized there's a lot more. And so CPC for kids also has some great resources that you can use. We're going to implement sort of that track sort of from got transition, then really beginning it at age 17, just kind of following it over time. So just thanks. This was really helpful. I appreciate you guys.
Can you share it with us too, Chris? And we'll share it with the participants.
Yeah, definitely.
Awesome. That'll be great.
It's in diabetes in particular, this becomes a hot topic because, one of the risk factors in type 1 diabetes is that DKA, and having somebody who then is unable to give a clear response to what their medical care needs are allows providers who may be in a hospital setting to proceed with care directed by whoever their trusted person is. For somebody who has a condition which may be particularly prone to hospital care, this is wonderful to have. And I appreciate every pediatrician on the planet who's willing to put some time and effort into transition planning. I have to say, this is sometimes a wonderful and smooth avenue, and sometimes a really rocky road. And all the effort that I see people putting in ahead of time just makes this so much better for our patients. And I appreciate every one of you.
And the appreciation goes the other way too, Betsy. We, as pediatricians, we very much value our adult medical providers who help us make that transition.
I think that's where we struggle too, right? Especially for those of us that aren't in sort of a larger adults, owned system, that we don't know who's out. Like, I get asked all the time, who should I go to? And I'm like, I don't know, ask your parents, right? That's hard to sort of figure out. Obviously, if, you're in a group health practice, there's a good chance you're probably going to be in the tri-health system somewhere. That may or may not be good care. I don't know. But I find that we really struggle with sort of like, I can point people in directions, but like when somebody's like, who would you go see? I'm like, I don't know. My primary care doc's not taking new patients. I don't know.
This comes up all the time. I have to say, one of the things I'm in random conversations at water aerobics, at the grocery store, with talking to neighbors, is like, who do you recommend I go see for this? Or I need a new PCP, mine retired. How do I find one? This happens all the time in many realms. So, and we all struggle with this.
I will jump in as we're sort of getting to 1 o'clock with a quick thank you to our partners at the Ohio Department of Health, and as well to our speakers, Dr. Lazaron and Dr. Bowling. Thank you both very much. To those of you still on the call, I again will be sending out either today or tomorrow an email on how to apply for CME and MOC Part 2, as well as links to a recording of today's video and then the slides so that you can access all of those resources that we mentioned. And if you have any other questions about the Preventative Health Program, always feel free to reach out to me at the AAP. Otherwise, thank you, everyone, and we hope you have a great weekend.
Bye-bye.